I will sort of run through various sort of procedures, but we can't start the meeting until what we call our quorate. We've had some apologies tonight. So we're waiting for Councillor Joe Lever to arrive, right? If we're not quorate, we can still have the meeting. It's just that we can't actually make any decisions, all right? It won't be a public meeting. So, but I am assured he's on his way, and he will be. But I'll to save. Oh, he's 5 minutes away, so he'll be running up the stairs. So as soon as he's here, then we can start. But I'll just go through, because your guests, just to go through the fire procedures. That if a fire bell goes off, it is an emergency. So there isn't any practice. So please make note. So if you hear the fire alarm sound, please treat it as a real emergency and evacuate the building via the nearest safe escape route. The nearest escape route is via the stairs to your left as you leave the council chamber or public gallery. There's no one up there. Exit via the door at the back of the building and walk across the inner car park to the evacuation point, which is the pavement opposite the police station. The lifts can't be used in the event of an emergency, and please do not re-enter the building until you're advised it's safe to do so by a member of staff. I will welcome everyone. Thank you for men only for coming along, and also thank you, Jackie, coming from Tower Surgery, and Dr. Dan O'Neill from Tower Surgery. So I think it's very relevant because we'll also be talking about the new mental health trust, Leslie. So it'd be very good to get a primary care experience on the ground, which can feed into the trust as well. So welcome Juliet, Leslie, Tasha, and Debbie. Helping me tonight, you've got Megan and Melanie, part of the Scrutiny team. I'm Councillor Michael Lilly, the chair of Scrutiny. My colleague, Councillor John Nicholson, is vice chair, and Councillor Peter Spink is a member. We should have another member, Councillor Joe Lever, shortly arriving. Chris Hopkin from Health Watch Isle of Wight, and Joanna from Health Watch Isle of Wight. And just for information, is the Health Scrutiny and Social Care, Policy and Scrutiny Committee for Health and Social Care. We particularly have a relationship with Isle of Wight Health Watch, who are actually built into legislation and link this committee up to the Health Select Committee at Parliament. It's the one committee on the council that does have a direct link to Parliament with that. So it's quite interesting, and it is the committee that all the public health providers, whether they're the Isle of Wight Council, the NHS, the new Hampshire ICB, etc., actually are expected to come and be scrutinised within that. Okay. Is there any questions people want to ask before we start the meeting? I'm sort of filling in time for a member to actually be here. All right. No. Yeah. That's better. We should be. Oh, there's Joe. Well, hopefully you're early on in the meeting, item 7. So hopefully that, and I'll keep an eye on that. But I would have thought by 6, you need to leave by 6:30. Hold me responsible to make sure that we get through that. Okay. Thank you, Joe. Right. It's here. We are now quorate, so I can officially start the meeting 5 minutes past. One, apologies, and we've received apologies from Councillor Warren, Councillor Downer and Councillor Robertson. No one else? No. I do notice that we have online Robert Ebbs, Laura Gordian, Wendy Pereira and Simon Bryant, and Gavin Foster, who, so welcome to you online. Minutes at the last meeting. Can I have a proposer for these as a true record?
Happy to propose, Chair.
Yeah, we've got proposal from thing. Can I have a seconder? Councillor Lever. Is the committee okay for me to sign them? Yeah. Okay, let's sign them. Want to initial them? Any declarations of interests? Committee members? No?
Michael,
Oh,
just for information, my daughter is now an employee of the Isle of Wight Council.
okay. We make a note. Thank you. Item 4, public question times. Have we received any public questions? No, and there's nobody I can see in the gallery. So there are no public questions. 5, progress update, pages 11 to 12. Quickly, this was progress on actions and outcomes. We just go through them because I know that there's probably a few questions members want to ask. In June, we had about the ambulance service, the 111 service. We haven't received any response. Committee members got some comments on that? Chris, sorry, John?
Yeah, I just wondered why, if there's an explanation for not receiving response, but presumably the data is freely available. So it's a bit disappointing that since June we haven't had a response to that request.
Yeah. Is it possible we can have a response by our next meeting in March? Because that would be quite a long time since we asked for that information. So if we could put that we get a response. Thank you. Question was raised about compliance of accessibility of standards. Says here the issues have been raised and feedback will be provided at the 4th of December committee meeting, which is today. Have we got anything from the ICB?
So I have been asked to look at this, and it's difficult because it's actually quite vague in terms of what the detail is that's required. There's a full statement on accessibility standards on the ICB website. I can get further information from our equality and diversity team if I knew exactly what the query was from the public. And staff at the ICB can be contacted through the main ICB switchboard, which gives an option to speak directly to the Isle of Wight Place team. Do sometimes have to leave a message, but we have a rota to respond to that. So it is always possible to contact local ICB staff. So I don't know quite how else I can answer that without further detail about what the problem was.
The problem is quite an unbelievable problem. It's been going on for years, and it's patients complaining that they're not receiving when they need large print. They're not receiving their appointment details in large print. It's really quite simple, and it's quite unbelievable that it's been going on for so many years. But it's not just that. Apparently, the eye department in Portsmouth informed a patient who travels to Portsmouth to receive his treatment, they were no longer going to send letters out, only electronic, and he can't see. So, or difficult to see, read text. So I don't know where that's got to, but it's all to do with the same thing. Thinking of the disabilities that patients who are receiving treatment have and need to be able to read their appointments. It's quite simple. And I mean, I think the comment was before, if the integrated care board can't get that right, then it doesn't give you a lot of confidence for anything else. It's such a simple issue, and it is the law, and it is the commissioners that should be enforcing the law. Got that quite clear.
I'm really happy to take that away and talk to the
Thank you.
providers again, and see if we can come back with a better statement
I
about.
know you're standing in, Natasha, but you know,
I'm really happy to take it away and talk to the providers about it.
the organisation, it's really not good enough.
Okay, can you bring that back? There was an update about the 51 shop elections.
Oh, blimey, I'm on a roll here. Sharp spins, right. So
Can
we all know that patients who have to use sharps, and sharps can be quite big. Apparently, you can't get 5 litre bins, or if you can get like 5 litre bins, such is the state of our integrated services that nobody can collect the damn things. So this has been kicking around for quite some time, and I think we spoke quite sternly about it at the last meeting and the meeting before that, and nobody wants to take ownership of it. And I think Healthwatch have got something interesting to say on this, because it's just another problem. I mean, you know, really, it's not good enough.
Joanna, I know you've got a view on an update on this.
Thank you. Yes, I agree with Councillor Nicholson. We had some feedback today from a gentleman whose wife is type 1 diabetic, and she uses the new insulin pump device. So the syringe bit has to be changed at least every 10 days, and they can only fit one of those attachments into the sharp spin. So she needs one sharp spin every 10 days, and he can't get them. So he goes to the local pharmacy, and they either don't have any bins, or they can only give him one. And then he'll go back 2 weeks' time. So he went today to take in his full sharp spin and exchange them for an empty one. And they only had 2 left in the store. So if someone goes in now, they won't have any for anybody else. And it's a real problem. And we understand that people are putting sharps, wrapping them in newspaper and putting them in black bags to dispose of them because they can't get hold of bins. And it's a problem for the pharmacies as well, because they don't know when they're going to be collected and when they're going to get new bins either. So they can't tell people when they can expect any bins. So it is a problem for people, and it's a public health risk if people are disposing of them with the only option they've got. So yeah, we're quite concerned about that.
Can we put forward, so from the service director, who's responsible? Sorry, who's the service director? Can we go back to Natasha and say, we have not had a response, we want a detailed response? Thank you. And can we put this extra information that's been given by Healthwatch in that regard? Dementia strategy, we had about the Afton ward pilot scheme. I was going to see, can we bring this up when we talk about the fusion project, or
the pilot's ongoing. We could bring the outcome of the pilot to the next scrutiny committee, if that would be helpful. No, absolutely. That would be great. Thank you.
Sorry, thank you. A meeting in March, yeah. Patient transport, we've had letters that have been circulated to the committee from the three providers, which were Red Funnel, Bobber Travel and White Link. Haven't members got any sort of view about what our sort of response? I thought it would be good if we could send the letters on to our NHS partners, stakeholders, to be able to look at those responses from the three and see how that links with the, I suppose, the responses that you are getting. But Natasha, would you like to make a comment?
So we had a successful patient transport task force meeting last week with all of the ferry providers. And there is work ongoing as a result of that task force, and another meeting is set up for late January. So we are moving in the right direction, although slowly, but there is progress.
Yes, Councillor Mosdell, would you like to?
Thank you. In the past, the Isle of Wight Council had a seat at that patient transport group. Who is representing the council as part of your patient transport group?
And I can't recollect, I'm afraid, and I'm not sure that there was somebody there from the council, but really happy for the council to be on the group. There's no reason not to be. If we can find somebody appropriate that wants to be part of it, not a problem at all.
Not to take over this meeting, but can I suggest that it's the chair of this meeting ensures that somebody does go to that meeting, because it's such an important issue that we've been involved in for years, and it saddens me that nobody from the council was actually attending that meeting.
Why don't I supply the details to?
I'm under the belief, perhaps we can check this, that the cabinet member for transport, this is Councillor Jordan, who's also now the leader of the Isle of Wight Council, used to go to those meetings. But if we can actually confirm that, and yes, if we can put it on our, if we can make a note to make sure that there is a representative, and there's also a report back to this committee as well.
Thank you. If I may, Chair, I have a feeling that it has come up that Councillor Jordan, we have actually allocated it to somebody. I think I know who it is, but I will double check. But it's probably clear that there wasn't a representative at the last meeting. So I think it's absolutely right that we ensure that where possible there is a representative at the next meeting, but I will double check to see if a substitute has already been agreed within our number.
Thank you. Back. Yes, Councillor.
Can I just say, in the past, it was always the cabinet member for adult social care, because I always used to go once upon a time. So just.
Okay, thank you. Councillor Spink.
Thank you, Chair. It may just be because I'm the new boy here and it's my first committee meeting, but I don't think I've seen any of the responses. They're not in this bundle. It does say here that responses have been received and circulated to committee members. I don't think I've seen any, unless they're in my emails and I haven't spotted it or something. But have they been sent?
Have they been sent to Councillor Spink?
They have been circulated to the committee, but it may have been before you were assigned to the committee, so I will make sure they're sent.
No, that's fine. Could you just send them to me in that case? Because I'd like to see the response. And may I just ask another question? Again, it may be me just being new, but when I read this, I was a bit surprised that the NHS don't pay for travel or indeed overnight accommodation if it's necessary. And then in our little informal meeting, I explored it a bit further, and it seems that the commissioners, I think it is, do pay in certain circumstances. Is it possible just to know what the circumstances are, or to send some documentation about that, please?
Really happy to supply detail outside the meeting. The NHS doesn't ordinarily pay for travel for patients. There are certain circumstances where patients can access funding, for example, low income families, or if they meet certain criteria. More than happy to supply that.
I think one of the points that I think wanted to raise, one was to clarify all the information, because I think one of the things that various transport patient user groups have still find it confusing where to actually get all the information from. And also this issue about letters that some of the travel operations, I think particular White Link, require a letter, and some departments don't actually supply that, and some only supply text within that. So it'd be we need to get some equality of that, that's exactly what is actually needed and what can actually suffice. Thank you.
So that was the key action that came out of the last Patient Transport Task Force meeting. We're producing a new communication leaflet for all patients who need to travel, pointing them to the right places to get the information they need about how to access discounted fares, how to book on sailings that would allow them to stay in their vehicle, and the production of a letter which is sufficient for the needs of the transport company, but doesn't reveal any confidential information about that patient's treatment that they're going for. So all of that was covered and is a work in progress for the end of January.
Thank you. We're on to item 6, which I'll put into context. Whilst I put it in the context, can you set up the film? Yeah. This item was sort of started last meeting. The idea is to have the voice of the lived experience of particular health issues. So last time we particularly had patient travel, we had the dementia strategy. We'll talk about that, and some of the third one. That was the dementia. I think we had other, but the idea is to have the voice, particularly from our list of priorities. Mental health, we've moved it, called it mental wealth on the request of the Director of Adult Social Care, Laura Gordian, thought that there was a wealth of activity going on amongst service users. So that's why we've called it mental wealth, right? As a section. And the idea is tonight is to hear from a couple of projects that are particularly were being funded through a small mental health grant fund through public health, to get more involvement of grassroots groups. That fund has funded about 28 projects at grassroots level to get more organisations and community organisations and service users involved in what's called the Mental Health Alliance, which is a network of that, and then that feeds into secondary services. So it's very much at grassroots level. So I've invited tonight the Men Only project, which I'm sure they will introduce themselves. And what's interesting about Men Only's project is we've got the opportunity from a GP surgery to actually say how they interact with secondary services within that. We're going to start with a film which was made by a project called Isle Access. It's only 5 minutes, and it's about the perspective of young people. Because mental health is from 0 to 100, we thought tonight, if we're going to present mental health, it would be good to have the voice of young people as well as the voice of adults as well. So we're going to just show this very short film, which was funded by the Isle of Wight Council through Public Health. So do the technology.
The most beautiful beaches, brilliant music festivals. So why do almost half of all young people here feel terribly alone or isolated? My name is Jackson Peace, and I was in that half of respondents who knows what loneliness here feels like. Geographically separate, socially alienating, and when the pandemic hit, you know the rest. Right now, support services for young people are at a breaking point. It's near impossible to even get a referral. I'm here at Department today to talk to young people about their struggles.
Mental health services on the Isle of Wight for young people are probably the worst they've ever been in my professional career. I've never seen it this dire, this situation. It's unprecedented.
I'm Luke, I'm 19 years old. I personally think it's a growing thing that a lot of young people that have moved here, like myself, are experiencing loneliness. I say it's a very common thing.
So tell me about when you first moved here.
Difficult, very difficult, because obviously new people, I don't know anyone. And the only time I had a collection of people was when I was in education, and that's come to an end. So now I'm kind of alone.
Hi, I'm Robin and I'm 16. Lockdown was really tough for me. It was a horrible experience. I lost all my sort of socialising skills. I struggled with the education side as I've got dyslexia. Pre-COVID, I could sort of speak to many people, but during and after COVID, I lost touch with who I was.
My name is Isaac, I'm 21 years old. The last few years, just being trapped in my room on my own constantly, I don't even know how to put it into words, it's just really difficult. I kind of just spend all day wishing that I was dead. I don't know what to do. I feel completely helpless. It's not like I can just go outside and go somewhere and start, fixing my problems. All I can really do is just go on the internet and try and forget that I exist.
My name is Christian and I'm 16 years old. I use a walker and a wheelchair mainly. Obviously the buses are very unpredictable, and obviously I can't always predict how long it's going to take me to do things. If I'm not going out, I'm playing games, and obviously that's not great to do all day, and I don't want to do that all day, but there's nothing else to do.
My name is Leisha and I'm 20 years old. So I went to high school when it all started, and I just started getting really, really badly bullied. Like, students were being nasty, even the teachers were being nasty. Like, they would sit me at the back of the class and just basically treat me like I'm just a brick wall. With my mental health, I've obviously felt lonely at times where, like, I would just go out for a walk and just have, like, breakdowns where I'm just sitting on a bench just sobbing, like, my heart out. And, like, especially with last year, I felt like I failed everything last year, where I just didn't want to basically not be in the world anymore. I just completely lost hope.
Being a young adult is usually the part of people's lives that they look back on fondly. It's meant to be the highlight, but for me it's just kind of been nothing. I feel like I've lost it all. I feel completely aimless, thinking about how many years I've wasted not having any friends, not developing myself or doing anything.
It's common belief that the island is devoid of opportunities for young people. But does it have to be this way?
Young people should have a voice. That's just basic, surely. They deserve a voice, and actually their voice is really valuable.
One thing that needs to change is that disabled people, especially after lockdown, need more help getting back into the world socially and making sure they feel supported and listened to.
I want social spaces for young people. I want a lot more social spaces for young people. I struggle with it a lot.
Something that would help would be better access to mental health services on the Isle of Wight.
I just want to be supported and emotionally and socialise much more.
I just want somewhere I can go where I can meet other people around my age, people like me. I think projects like this are really starting to give me hope that that may be possible, at least in the future.
It's a very moving film, and I'm very proud that this council actually funded that and made that available. If we go straight on to now the adult end side of it, and that vignette, over to you, Carl, if you'd like to introduce yourself.
Thank you, Michael. My name's Carl Hart. I'm the Managing Director and founder of Men Only Isle of Wight. And with me is Josh Driver, who's quite anxious at the moment. But Josh is one of our service users and has been with us for about 18 months now. Yeah. This project came about when I moved back to the island in 2020. I'd been living in Portsmouth. Before that, I'd been abroad. I came back and I was horrified at the statistics for male suicide in the UK. And we are now just getting the figures from 2021 and 2022 because they were delayed due to COVID. So the reporting of those figures and the numbers are still going up, 10 men in the UK every single day. So like most people, you can sit there and be, upset by what you read, or you can get up and do something. So I started a very small, low-key Zoom call system for men. We did 3 hours on a Monday, 3 hours on a Friday. It was an open call, and if people wanted to join in, they could. I spent a lot of Mondays and Fridays on my own, reading books and waiting for people to join. Eventually, they did start to come along. That came about around about the end of the lockdowns, the final bits of the lockdowns. So in September 2021, we started doing a walk and talk group. So having never done something like this, wasn't sure what the response was going to be. We did a very low-key media project to see if we could get people to come along. Michael came along to that first walk, and we had about 30 guys show up. It was very, very reassuring. And we all went off and we walked and we talked, and the response was very favourable. However, the following week, nobody turned up, nor the following week, nor the week after that. But eventually, and we've been going just over 2 years now, we built up a group of about 13 to 20 guys that will come along most Sundays, whatever the weather, and go for a walk, 20 minutes, half an hour, then sit and have a cup of tea and chat to each other as much as anything else. And then they can come to me or any of the volunteers that we have with us to get that sort of support. So having done that for about a year, realised that there was probably still something missing and more that we could do. So we were able to get some space at the depository in Ryde in Nelson Street, which is an old Methodist church. It was very, very cold. It was very miserable. We got there in September and it was absolutely freezing. However, we opened the doors, said we were going to be there. First week, we had about 5 guys came through the door, drank cold tea and left. The following week, we had 10. The week after that, we had 20. And then we opened on Christmas Day last year and had about 14 people come through on Christmas Day, which is notable because they were all single men. that came in and half froze to death and sort of survived on mince pies and turkey rolls. In May of this year, we acquired a property in the High Street in Ryde, number 134. It's been named after two young men from the island who took their own lives. So it's Roger and Steve's place. We're a warm space, safe place. We've just fitted a brand new kitchen in the place so we can provide hot meals. And we're now seeing about 60 to 65 guys a week. So that sounds like an impressive number, but I have to be honest, it's not 60 or 65 new people every week, but it has become a centre for people to come back time after time. They've created friendships, they've created a better life for themselves. We've been able to get people into houses that were, homeless or potentially homeless. And the connection between ourselves and Tower House is the MAC team, the Mental Health Access Coordinators. Is that right? Yeah, first time I got that right. Because a lot of things, there's a poor education around men and mental health. Men and their families will come and talk to us and say, yeah, but it's different for men than it is for women. And it totally isn't. The NHS is not discriminatory in any way. It doesn't, you don't have special treatment for women and less treatment for men. The challenge is, and the lack of education comes, is that men work differently. We don't like to ask for help. We don't want to seem weak. And, secondly, and probably the key thing is rejection. So we will go and ask for help. And if somebody says, oh, well, we can't get you in for 12 weeks, we'll not go back again. So one of the key things that we've been able to do, thanks to the relationship we've got with Tower House and Jackie and Dr. Dan O'Neill, is that we have access to their coordinators by email or phone. Somebody comes in, they're in crisis. We're then able to, on their behalf and with their permission, get straight in touch with the access coordinators. And on many occasions, they'll come back the same day, sometimes within a couple of hours, make an appointment for somebody to go in or have a chat and then continue that treatment further. And I think that's really important. And that's one of the biggest things that we aim to do. Yes, we're a drop-in centre. Yeah, we can provide tea and biscuits and we can chat and watch the TV. But the key thing is to get help for people, for men who desperately need it and don't know how to ask. That lack of education goes both sides as well, because I think, we're currently having a situation with the Isle of Wight Council Housing Department, because a single man with no dependents who is about to become homeless will ring up to see what his opportunities are. He'll be told to join the list and house watch, but probably isn't going to get anything for 2 to 3 years. They won't bother trying again. They'll sofa surf or they'll move away or worst case scenario. And I won't bore you with the statistics of suicide. I'm sure you're all very aware of them. But that's what happens, is eventually they reach a point where they hit this impasse where they don't feel like anybody's helping them. They don't know what to do. They feel worthless. Their sort of point in life has gone. And so they will, take their own lives generally. And men are very successful at it, very successful. So I think the key thing is to highlight the fact that we're a third sector organisation. We don't receive consistent funding from anybody. We go out, we apply for grants, and yes, we have had a lot of support from public health. We received a grant last year, which is being used to provide a truck that will go around the island. So we'll have that warm space, safe place, not just in Ryde, but wherever we can park up. If we can get a parking organised with the Isle of Wight Council, just sort of drop that one in for you lads. So we're trying our best. And I think the highlight has come for me that the more people I talk to in other voluntary sector and third sector groups is that we're a bridge, effectively we're a bridge between the service user, in our case, specifically men, and mental health services. We know what to ask for, we know how to ask, we know how to get people into the system, but they don't. And as the key thing is, without the support of Jackie and Sarah, Caitlin, and Dr. Dan O'Neill, we wouldn't be able to do that. But this is a very, very good relationship, and it's something that should be looked at in more detail, I believe. I'm not trying to big up what we do, but we're a very, ourselves, the Veterans Hub, Aspire, and other third sector groups, some of them really small, maybe just 2 or 3 people doing it, are a very, very important bridge into mental health services. They come to us because they feel safe. you know, and they feel able to ask questions. They come to us because we will pick the phone up for them and make the calls and know the right things to say so that they get the support. So I think it's important for all, especially now with this new infusion project coming in next year. It's important, I think, for you to look at what's happening, you know, at grassroots level and seeing how that can be supported and how we can support you. Because as I say, this relationship that we have with telehouse surgery is amazing. That, you know, if we can take somebody who is on the verge of a breakdown or potentially worse, and we can get them in to speak to, you know, somebody within at least a few days at the most, I think that's hugely important. Joss has come along because he's offered to share his story with you, and I think it's a very important one because, you know, I think when we think about men with mental health issues, we think of drug or alcohol abuse, people that are self-medicating, they're homeless, they come from broken families, but it's not the case. The key thing with mental health, and I'm probably preaching to the choir on some of this, but it's, again, mental health is not discriminatory either. It doesn't care how much money you've got, how poor you are, you know, how popular or anything else. If you've got it, you've got it. And if it's going to affect you, it will affect you. So having effective support is hugely, hugely important. So, you ready? I'm going to hand over to Joss. He's just going to tell you a little bit about his story. I think it's quite an interesting one. Got this, champ.
Good evening, everybody. I'm Joss Driver. I'm 54 years old. I come from a very, very normal background. High school, apprenticeships, nothing out of the ordinary. I'm the bloke next door. So basically, I'll give you a little bit of a background to me. I'm ex-forces. I'm ex-prison service. I did 22 years on the island and on the mainland, covering professional standards, drug dog handler, intervention teams. I also was a member of the Coast Guard service. I did 13 years. I did multiple body retrievals from height. I've witnessed suicides. I've witnessed self-mutilation, numerous things that you don't really want to be involved in, but you are through what you do. Approximately 2.5 years ago, I was involved in an RTC where I wasn't injured. I was going under blue lights and sirens to a casualty. Unfortunately, the casualty died because we didn't get there. As a result of the RTC, one of my colleagues was injured extremely badly. And it sent me into a spiral of depression, suicidal tendencies. I withdrew to the extent I couldn't eat. I couldn't dress myself. I didn't know what clothes to put on. I couldn't leave the front door. And I didn't know what to do. I was just absolutely in pieces. I was very, very emotional. I would cry for 6 to 10 hours a day, depending on if I was sleeping and if I didn't sleep. And then after that, I decided to get some help. So I went to the Coast Guard service and said, can I have some support? They gave me a number with a series of counselling sessions. On the first counselling session, they stated that I was too broken and that I could not undertake their services because they were scared of what was going to be unlocked. So I then went to my GP. My GP immediately put me on some antidepressants and said I needed to self-refer to, I think it was called Charterhouse, Chantry House. So I went and self-referred. I got a telephone appointment about a week later, and they asked me if I'd had any suicidal thoughts. Now, approximately a month prior to that, I'd had an episode where I planned and was about to carry out my suicide. So I was in a position where I was quite happy to kill myself and take my own life. There was no way out of it. Once that had passed through a absolute fluke, it was a phone call that had interacted and stopped my train of thought. And I was lucky enough to have some people around me that actually took me and spoke to me and put me in a better place. After they said, have you got any suicidal thoughts? And I said, no, I haven't got any suicidal thoughts in the last 7 days. Prior to that, I planned to take my own life. Keep taking the medication, you'll be fine. And we'll assess you in another 3 to 5 months' time. I couldn't wait that long. So I actually went private, found a psychiatrist on the island, and undertook EMDR. You know, EMDR for me was singly the best thing that I could have ever done. So it basically recalibrated my mind. And I was diagnosed with complex PTSD that I'd suffered with for approximately 30, 35 years, unknowingly. And the catalyst was the car accident. So after a session of 17, 18 sessions that I paid for, I met Men Only. And through their support, it actually got me through a lot of other circumstances. I.e., as I was going through my EMDR, my marriage broke down. That was 34 years I was married for, and the divorce has just going to become final. So not only do you deal with PTSD, not only do you deal with a divorce, you have to deal with your day-to-day lifestyle. And in this day and age, it's pretty crap, unfortunately. And if it hadn't been for him and the team that he has on board, and the other people that suffer with mental health condition that go along, yeah, I would be here. There's no doubt about that. So I am living proof that his system works. Anybody got any questions that they want to ask me? I am an open book. I do not mind anybody asking me anything at all. No?
We could have the input from you, Daniel, from the GP surgery, and obviously from you, Jackie, your interaction with this project, right?
So I got involved when 2021, when Carl was advertising it all on Facebook, and I kind of reached out and said, I think this is brilliant what you're doing. If you need any help, give us a shout. I'm the mental health nurse in practice. So we'd set this up in 2019. I used to work for the trust, and we set up a mental health nurse in GP practice so that patients can come direct to a mental health nurse specialist. We can prescribe and diagnose, prescribe, treat patients without the need to go through GP. So they can come through a mental health nurse. So we kind of run, there's 3 of us now. It was just me at the time, but there's 3 nurses now that work in practice. So so I kind of said to Carl, you know, if you need any support, come to us, need any help, come to us. I rocked up at the first walk with my dog, and we kind of stayed in touch that way, and I refer a lot of people to him and he refers a lot of people to me. And it's not just about Carl having a way into services, it's also about us having somebody to refer patients into for that extra support. So it works both ways. So if Carl's worried about somebody, you know, he'll say, oh, can you just see this chap and look at his medication? If I'm worried about somebody, you know, I'll say, oh, go and see this idiot down in Rise, you know, and it just works really well.
Yeah.
It works both ways. It's a proper holistic kind of support system, really. Symbiotic. So it's kind of it's a team.
Yeah.
It's a whole team, but there needs to be more people in Carl's bit of a team, because he's very much doing it on his own. Whereas I've got the whole GP surgery and NHS people with me. There needs to be more people in your bits.
Yeah.
Thank you. I think huge amounts already been said there, which from my perspective, I think a really good example of moving forward, we have to recognise with the increasing demands, increasing complexity, we have to be working as a system. We have to be communicating with each other. Everybody's different, and there isn't a single pathway that say will always work for everybody. We have to be open to flexibility to try and support what's right for individuals. So some people, for example, may say that the access that they always know is through the GP. That's something that they've always done when they're unwell and there's a problem, they see their GP. We've tried to create that open access for all GP surgeries, and that's the mental health access coordinators that Carl describes. Although they work from Tower House, they provide across the services for all of the practices. So all the 12 practices trying to work together in a uniformed way for all people. What the basis of that is to understand what the other options are. So it may well be that even though you come to the GP surgery as your first point of call, it may be that actually the support that Carl can offer is vastly better than taking medication. And so by understanding an entire system, we hope to be able to educate people to say that these are your options. You know, medical option, getting support from Carl, wellbeing service, lots of different options which are available to you, and educating what those are and allowing the person as the expert on themselves to be able to make the choice as to where their start point into the system is. But if then actually once they get through to Carl, for example, then that relationship works both ways. So they then have the relationship back to the sort of medical support as well. So somebody who really absolutely does not want to come to their GP under any circumstances and is very averse for the medical model, they come through to Carl, and actually by coming through that system, he can then say, well, actually, I know that I know that practice. I know that you'll get this support. So again, I think that as we move forward, really, really important that we work as a system, and I obviously work very closely with Leslie trying to create what the No Wrong Door project. This is part of that, to say, well, actually, let's create a system where we all talk to each other. We all can do whatever is in the best interest of the individual who comes forward to support us. And I think that what the work Carl has done is fantastic, supported with Jackie. So, you know, it's hopefully a great example of what we need to expand out further.
Covering all the bases.
Sorry.
I think the key thing is sometimes the NHS going to a doctor and saying what's wrong with you, speaking as a man for men specifically, can be daunting at the best of times, because generally, although poor mental health can come at any time, the key thing is it is generally triggered by an event, a breakdown of a marriage or relationship, a loss of a loved one or parent, loss of a job, and maybe even just losing your direction in society. It can be something that is not, it can be triggered by anything. And going through to a GP and saying, I feel really crap and I don't know why and I don't know what to do, can be daunting. It really can. I think the key things for projects such as ours is that we take away that intimidation, if you like. Somebody can come in, sit down, have a cup of tea, you know, and we tend to start all the conversations with, what's been going on then? You know, we do that very low key, not what's wrong, how are you? It's generally, let's talk about your life and where you are. And like Dan said, it is important that we can then with confidence say, look, we've got this really great relationship with Tower House Surgery. Let's get you into one of the access coordinators. Doesn't matter what practice you're registered with, they work with all of them. So they'll be able to liaise with that. Let's look at that. If you're already on medication, maybe you need a review, maybe you need a little bit more, maybe you need a little bit less or something different. Being able to provide that information so that they can go with a level of confidence and this, you know, not knowing that they're not going on their own, or there's, you know, they're out there trying to deal with everything, is really working well. And this is something I've mentioned to Michael in the past. We live in what is essentially a very large town. This island has 144,000 people in it. I lived in Portsmouth, it had 275,000 people living in a smaller area. The opportunities are there for us to create a blueprint for highly effective mental health services here with what we've got on our doorstep. We can create new systems, we can trial them, we can run them, and they can be rolled out, you know, nationwide after that. Because we have such a small community, these guys work with, the access coordinators work with all the GP practices. We have a small community, and there is a lot of people like me. I'm not unique. There's a lot of people out there that really care and want to get out. So if we create those partnerships in this petri dish, if you like, that we have here, that works perfectly, we can create a hugely and highly effective mental health service for men, women, young people. And I just want to refer back to the video quickly and then I'll wrap up because I know some of us have to get away. The interesting thing on those interviews they did, 4 boys and 2 girls, which almost matches the number of men to women that go missing and are never found or take their own lives. It's currently 3 to 2, 3 to women, 3 men to women. But it's the same sort of number. And it was very interesting to see, even at that age, those numbers correlated. 2 girls, 4 boys. So I'm not saying we're special, but we are in need of getting that little bit of extra support. And I think it's really important that that's what we take away from this tonight, is to know that there is services out there that just need to be supported, liaised with, and grown. So thank you very much for the opportunity to come.
Thank you very, very much, and thank you for. It's a very brave and a courageous thing to actually come in front of a group of strangers to actually be able to do that. But I think the important thing, and I think when we go on to talk about a fusion project, is some years ago, from my experience, and I know from the Isle of Wight Health Watch, we didn't have that joined up kind of link. There wasn't that link at the grassroots through the primary care through to there wasn't this discussion. So thank you for having this discussion tonight, and actually proves that grassroots projects are doing some great work. And I think there was a very similar experience in Ventnor when we visited Ventnor, that they had a similar link to their GPs, and so in West White there is this similar route. So over the last couple of years you started to have that joined, do I dare say it, joined up thinking, which is one thing that we don't want to lose sight of.
Sure. If it's all right, Mr. Driver, I'd like to ask you a question. I'm very struck by your story, and indeed, you know, that you're an ordinary chap off the street who's done some ordinary jobs, and I just wondered if, when you look back at your life story, were there any triggers that knowing what you know now could have been picked up in any way that had averted the state that you got in? Because it seems like, you know, we're very good at treating once the horse is bolted, but not very good at
No, you're totally
keeping
right.
the stable doors
Totally
shut.
right. So all my life I've worked in a male, potentially male orientated environment. That is uniformed, it's testosterone based, you're dealing with people that are unpredictable, and you're going into situations that are potentially volatile. Crying and showing your emotions are a sign of weakness. So my first issue that I had was when I was 16 years old. And I was told to man up, get on with it, put your big boy pants on, you'll get over it. And then as my life progressed, the early 20s, I was involved in numerous major certain disciplines, major fires. And again, it was a case of just sort yourself out. Go to the pub, have a couple of pints, put it to the back of your mind, you'll get over it. And it was absolutely fine. And then when I started to deal with dead people and picking up loved ones and dealing with children especially that have passed, those are the things that you can't get out of your mind. And those are the things you relive on a day-to-day basis. Now, every one of my major traumas could have been identified and dealt with at that particular time. And I potentially think that I wouldn't have been in this position if I'd have got that help or were made aware that it would have a knock-on effect in my latter years rather than just suppressing it. And to admit to myself that I've now looked back and thought, yeah, this is all, you could have changed everything and your life would have been potentially normal. My life is normal now, but I deal with a condition on a day-to-day basis. And you can tell when I'm speaking that my voice gets very broken and very nervous and like I'm going to burst into tears. And that's because I'm so passionate about what this is all about. Men's mental health in general, not just men, sorry. But for me, men's mental health is a thing that is overlooked and becomes so difficult for a testosterone-based male to admit that he's got. It's phenomenal. And I am an open book. If any one of you asked me a question, I would answer it honestly. It may not be what you wanted to hear, but you will get that answer because I've got nothing to prove now. I've been to the worst place that anybody could ever imagine. And that is something that I will hold in my heart all the time, and I will do for the rest of my life. And I will make sure if I can make one person's difference, and if I can support him so somebody else doesn't die, that's all that needs to be done in my book.
Any other? We got to.
I just wondered if Leslie was going to make any comment.
Yes, I would, but I wondered whether I do that in the context of the Fusion paper, if that's.
I'm going to suggest, because of time, we move on to Fusion, because I think it's actually a nice link to the fact of reorganisation of mental health services, which are sort of, if we look at it, go from you to you, Daniel, and then round the corner to Leslie. So we've actually got all the partners linked in the room, which is a very rare commodity at this committee.
Yeah, and a fantastic.
So over to you to present about the future of our mental health services.
Thank you. And if it's all right with the committee, what I'd like to do is just to talk briefly about the paper that you've had, but then come back to the issues that you've raised, and both in the room and in the film. And again, thank you for sharing your story. So Project Fusion is the name that we've given to the project to develop a new community mental health and learning disability organisation across Hampshire and the Isle of Wight. It brings together community mental health and LD services on the island with Southern Health Solent and with child and adolescent mental health services in Hampshire delivered by Sussex Partnership. The intention is that we benefit from the large scale of the organisation through reducing unwarranted variation and making sure that we've got much improved access to services regardless of postcode, and that we're able to deliver a more sustainable service. And that's particularly an issue for the island where our scale is very small. And I think the things that you've talked about are areas of real focus that I'll come back to in terms of the improvement that we're wanting to make. The aim is for the new organisation to be formed by the 1st of April 2024, and we're on track with that. And since we last talked about this in Overview and Scrutiny, there have been a number of significant developments. We have signed off the full business case and submitted it to NHS England, and the NHS England review process to enable this transaction to happen is underway. We're not expecting anything to get in the way of that. The chief executive and chair for the new organisation have been appointed. Non-exec directors have been appointed to the board, and that includes Sarah Weech, who is currently a non-exec director in the Isle of Wight. There's very detailed work going on to make sure that we're safe on day one and that the services come together. And our expectation is that there won't be a big bang change, but that as we come together, we then take the opportunities that come with working in a different way to improve our services. We're doing a lot of work around engagement with our staff, with people with lived experience, with our partners. And that's been really fundamental to developing the organisation. We've created a new name. We've agreed a new name, which is in the paper. It's called Hampshire and Isle of Wight Healthcare NHS Foundation Trust. And I think that's probably about all I was going to say from the paper. But just in response to some of the things that you've been talking about,
One of the real challenges for this organisation is that we have got the opportunity of large scale mental health services. And we also want to absolutely take advantage of delivery at place. So one of the challenges for us is how do you do both? In the island, we do place well, as you'd expect. Our place has got water around it. We know where it is. We know what all of our partners are, and we are able increasingly to create pathways, exactly as you say, that work through whole pathways of care. And when you look at what happens elsewhere in Hampshire and the Isle of Wight, it doesn't happen as effectively in other places as it does here. But what they do have the benefit of is large scale access to highly specialist services, access to training, supervision, support for staff that we just can't provide in our small scale. And so one of the real challenges for us is how do we do both and? How do we, as an island service, take advantage of all of the benefits of being part of a big specialist organisation whilst building on and actually sharing some of the expertise we have in the island around integrated provision. And we know, and Dan's part of the No Wrong Door work that happens across Hampshire and the Isle of Wight, and it's always one of the highlights, hearing some of the good work that happens in the Isle of Wight, isn't it? And I know that mainland partners are coming across and looking at some of those integrated primary care mental health pathways that I think are really well developed here, and that others can learn from. So there's a kind of quid pro quo in this, I think, for us on the island. We'll benefit and we can benefit partners. There are a number of things that we're really committed to in the new organisation that I think will be a step change to what we have now. One of them is around trauma-informed care, just responding directly to what you said, the kind of roles that you've had and the experiences that you've had. We know that mental health services expose staff to trauma, as well as do ambulance services and police, all of the other services that you've talked about. I'm now part of a Hampshire and Isle of Wight trauma-informed executive group that is led by Hampshire Constabulary, but actually involves the whole system, the whole of the IC, the integrated care partnerships, all of the partners. And we're making a real commitment within the new organisation that we will be trauma informed, both in terms of the way that we care for our staff, but also in terms of making sure that the skills of our staff allow them to recognise the kind of things that you're talking about, and to be sensitive to trauma in the way that they care for people. And I'm not just talking about mental health services, I'm talking about physical health community services as well, where all of the contact points that we have across our services. So that's a really important thing for us. The other thing that's really important is that we take a population health approach. So we're talking about community physical and mental health services, which means, and we also are an organisation that work with people from birth through to the end of life. And that gives us massive opportunity to intervene earlier, to look at the prevention, to be able to spot things and intervene, to be able to care for a child and look at the family. And at the moment we don't do that. I don't think that happens in Hampshire services either. We're very separate between physical and mental health, and very separate between children's services and adult services. And actually there's a real opportunity for us to start to do that internal joined up care within the new organisation. So we're really focused on that. And the other thing that we're working on is our relationship with the voluntary and charitable sector. And in fact, I was in a meeting just last week with the new chair, the designate chair of the organisation, with it was a community interest company on the mainland, who was talking about, I'm sure, all the things that you'd recognise: insecure funding being withdrawn at the last minute, providers not being available to meet, just having lack of clarity and certainty about what's able to be provided over a period of time, and yet being a really crucial part of the pathway. And one of the things that I think we've got an opportunity to do as the new organisation is to think differently about our relationship with the voluntary sector, and how we commission directly with them to be part of our pathways. And actually that work is being led by the Director of Operations from the island. He's leading it on behalf of, it's James Seward, who's leading it on behalf of the whole of the Fusion programme. And I was wondering if you'd mind if I introduce you to James to have that conversation, because I think having some of that, having advantage of your experience, I think would be really helpful in helping him formulate what he wants to do. The other thing I wanted to say is just in response to the film. It's really heartbreaking, I think, to see what has happened to our young people nationally and locally, particularly as a consequence of COVID. The referrals to child and adolescent mental health services has increased by something like 300% since COVID. The referral rates are not, they're staying high. There was a big peak post-COVID, particularly as children went back to school, but it's not fallen, it's continuing to be high. And so the levels of distress that we see in our young people as a consequence is persisting. And that's particularly being expressed in eating disorders. So there's been a particularly high rate of eating disorders. And just to give you some assurance, I heard messages about how difficult it is to access services, but just to assure you, we're working really hard on access and on increasing the support that we provide to children and young people, particularly young people as teenagers, I think, who are really getting the brunt of this. And we're having some success in that. So we have now mental health support teams working in all of our schools, and they are having some real success in increasing attendance. So we've seen a significant increase in attendance, and we're seeing a significant reduction in the number of young people who are accessing the mental health support teams, accessing their GP. So they're getting, and the support teams work directly with individual children, but they also work with the school community to make sure they're taking a good approach to mental health generally. We've put in place a holistic at home intensive team that's particularly around young people with eating disorders, and we have the lowest rate of inpatient admission, both to paediatric wards and to child and adolescent tier 4 beds across Hampshire and the Isle of Wight. And again, sharing with our partners some of the things that we're doing that enable us to maintain a really low level of admission. We've had to work really hard to catch up with the waiting. We grew big waiting lists as the demand increased, and we're really getting on top of that. So we're kind of back to where we were despite the increase in demand. And the final thing I wanted to say is a workforce thing. So last week, we got our Nursing Times Award in the Isle of Wight Trust for a school leavers apprenticeship scheme. And that's something we're so proud of. And just to link to some of the things that was said about the hope that we can provide for young people on the island and opportunities. The School Leavers Apprenticeship is for 16 to 18-year-olds who are interested in a career in health, probably don't have the qualifications to become a nurse or a doctor, but actually we give them access to a whole range of different jobs within health, including admin, some support worker things, corporate services. And we're working with HTN, and we have a very strong apprenticeship programme that allows them to experience different aspects of healthcare. And it's a really innovative programme that was recognised in a national award last week. That was all I wanted to say. Thank you.
I just wondered how this touched on public health, and whether Simon might like to tell us what public health involvement is.
Simon, are you there? There you are.
Yeah, hi, Chair. Sorry, I'm trying to manage a bit of parenting as well. You're absolutely right. I think public mental health is really, really important, and we acknowledge that. There's an awful lot of work we can do. We've got a really, really positive mental wellbeing and suicide prevention group on the island that really brings forward partnership work to improve health across the all ages, and that's a real kind of a group that partners with the work that Leslie's talking about around services. So I think as a society and as a system, we need to really think about how we improve the health of our population. As Leslie said, recognising that the impact of COVID has impacts on the mental health of our our population. But we're doing an awful lot of work around community resilience, around training, around understanding, and really improving those things that will have good resilience for our population of the island.
Can I just say, Simon, I think that here we've got, well, we've had two outcomes from Isle of Wight Men Only and the Isle Access, the young people film, that actually would have happened anyway, but actually happened very much through the grant fund. You know, they were boosted, as it were, through the public health grant fund. And I think that one of the things that we've definitely got through my visits and the visit through by Joanna and Isle of Wight Health Watch, that there's lots of these similar stories, and you are now got an infrastructure, particularly in your forum, your mental health alliance, that actually wasn't there fully 2 years ago. And I think it is there. And I think it's very proud that in your forum, you've actually got organisations like Isle of Wight Men Only.
You're right, the forum's a brilliant forum to bring people together to improve the health in a systematic way across the whole of the island. Also recognising people need the skills, and we're working with the ICB, who've got one of their priorities is mental health and well-being, and we're having a number of conversations to really think about how we do that together systematically. Think about the key things of employment and also volunteering, because we know they have a good impact on health. So those are the kind of things we're doing together, really positive work.
Yeah, sorry, Leslie, you're talking very openly about trauma. The trauma identification, talking from my experience, an email or a telephone call isn't enough. So I don't know how you're going to look at expanding on that, but it's got to be face to face. There's no other way of doing it.
The approach that we're talking about is with our starting point is training staff. So we're making sure that our staff have a really strong understanding of an approach to trauma, and we would expect mental health staff to have those skills anyway, but we won't exclude them from the training. But it's kind of broadening it out really widely to make sure that all all contacts that people have with services, they're talking to people who have a real understanding of trauma and are able to deal with it. And that might include phone calls, it might include whatever kind of contact people have. But I agree with you. You can't get past how important face-to-face is for many people.
My experience, I had a telephone call asking, was I all right? Or an email saying that if you felt traumatized, do this, this, and this. And as a bloke, that just doesn't happen. I'm sorry. But in the environments that you're looking at, ambulance service, police service, fire service, all those have their own trauma-based teams and that will manage it. But it's getting people to understand what that trauma is. What I class as a trauma and what you class as a trauma are two totally different things. So the spectrum is so vast. Thank you.
Joe.
Thank you, Chair. It's something like this subject is so broad and there's so many things that need to be done that it's kind of hard to focus it down. But I think one of the things I noted while you were talking, Leslie, I'm glad you mentioned it, was because I was thinking that the structure that we're seeing seems really good and it's understanding all the different parts that need to be joined up. But I guess my concern was that the arms or the branches, if you like, of this are reliant on organisations like Carl's almost as that connector. However, they're reliant on very precarious funding a lot of the time. So I'm really interested that we follow up that to make sure that there are ways that we can get these organisations the funding on a more sustained basis that they need, so that they're not just dropping off the face of the earth if they don't get some funding, and then it causes problems further down the line for you guys as well.
I couldn't agree more. And I think one of the issues is, and Dan mentioned it, the kind of medical model, isn't it? That there's a kind of sense that for a mental health service in the NHS that we have to be focused on a medical model, and that's absolutely not the right thing for us to do. We need to be focusing on supporting people in their recovery, and that usually very often will require non-medical interventions might be alongside medical interventions. And the risk in the medical model is that the kind of interventions you describe are not valued in the same way, and that's nonsense. When we know, when you look at the outcomes and the impact that they have, they should absolutely be valued in the same way. So when we're thinking about where we put our money and where we keep our money when times are hard, then it should include voluntary sector, and often it doesn't at the moment because we tend to retract into NHS services. So it's kind of shifting that mindset. I think it's really important.
Just to follow up, Chair, sorry, and kind of related to that, because a lot of this we're talking about prevention, right? Stopping things from getting so dire, and one of the things is making sure that the young people we saw on that film also don't come into situations like yourself that you've described, which is harrowing. And thank you for sharing that. So how do we stop that happening further down the line as well? And obviously it shows that we're going into school, we're talking to young people in schools and other outreach programs. So that's really great to understand. I'd just like us to follow up as a committee on how that's going and make sure that that is really at the core of what we're doing. Yeah,
I would be really happy to bring back more information about our child and adolescent services generally, including the mental health support team is something that we deliver with voluntary sector. So the Youth Trust and Barnardo's and child and adolescent mental health services from the Trust all working together. So I'd, yeah, be very happy to bring information about
I think I think we've got down next September. I think we've actually got you down to come back, right? So we would like, obviously, to come back within that. But I think it's important to emphasise that you can probably correct me on the statistic, but it's something like 70% of those who are now in acute mental health services were identified as children. But they actually didn't get the right help, and that's why they were there. So I mean, we do need the 0 to 100 or whatever, and to get those interventions in place to actually stop that happening.
I think again, it's often teenage years are the years where people often start to present with the kind of mental illnesses that we then see extend through to adulthood. And you'll be aware we have in the Trust an early intervention in psychosis service that runs from 14 through to adulthood, and works really well. But that's the only service that we have that bridges that adolescence, young adult gap. And actually, if you're 18 with a serious mental illness, you're not really an adult at that point, because it will have an impact on your maturity and development. And so extending to 25 or something along those lines makes much more sense. We really need to start to build those services that bridge that gap. 18 is too much of a cliff edge.
Just on that, you have a situation where you have funding. I know this through the Isle of Wight Youth Trust, is they have sort of funding for interventions, counselling, etc., up to 18, but their services for 18 to 25 have to rely on charitable money, which is absolutely appalling. There needs to be proper funding for that age group of 18 to 25 within that. At the moment, it totally relies on whether you get a lottery grant or of that. Then I've never understood why there hasn't been proper funding for 18 to 25, which happens in other parts of the country, but it seems to have failed on Isle of Wight. So please, with our report back, we would definitely, and I thank you for your commitment on about looking at the voluntary sector, because definitely from my experience with Isle of Wight Health Watch and visiting these projects, it's grassroots ones that really save lives, and we need to make sure that those do have funding, and they're not actually that expensive. So actually, value for money at that end is important. John, you wanted to come in?
Yeah, so we've got public health. Simon is quite rightly focused on the prevention. Leslie is once somebody's in crisis, but in between that, there seems to be plenty of missed opportunity to identify people building up into crisis. And your GP is a primary care is one, but when you can't get to see a doctor, it's not really very helpful. But there's other places as well. So there's workplaces. We have this mental health first aid awareness course, but I'm not too sure quite how practical what you're taught on that would be in identifying a case like Mr. Driver, and I imagine he's not alone. But last time I looked, GPs, and I'm looking at Dr. Dan here, I guess you're quite unique. GPs don't really get much background training on mental health. Am I right in still thinking that?
That's why you've got mental health nurses in all your GP surgeries.
Thank you for informing me.
Just saying.
Shows you how long it is since I've been to mine.
Can I just come back? I think there is certainly mental health training could be improved with the GPs. I think that's absolutely right. Obviously, general practice is a broad spectrum of different conditions, and I think what we have recognised is that having specialists in primary healthcare is crucial. And again, all the practices now across the island all do have specialist mental health services within the practices. I think we've recognised some of the benefits from the mental health access coordinators for adults, but again, that is an adult service at the moment. We're looking at how we can introduce that for all ages. I think that's a really crucial step forward, that we have access improved for primary healthcare, and the access coordinators will allow us to have very early access without having to necessarily go through and see a GP all the time. And the GP isn't necessarily the right person to be seeing a young person who's quite intimidated and quite scared of coming forward. So there is a plans to, as I said, to expand that out for all age service. There is within Newport a really interesting scheme where they have a care coordinator, a children and young persons care coordinator in place. So this is somebody with a sort of extensive mental health and education background, and they're providing some fantastic services to children and young people who just similar to what happens with regards to understanding the wider resources that are available to them and where they can go for help. And again, we're looking at working with that person, with our mental health access coordinators, as part of having an island-wide approach to how we can deal with that. So we very much recognise that children and young people aren't really getting that early access at the moment through primary health care. And I think if this works alongside the work which is happening in schools, we can have a really robust whole system approach for providing that support for children and young people. And as has been said before, it's a much more effective way of delivering care if we can do that at the earliest stage possible. I think the other thing is that just the work with Youth Trust and Isopropia, so a lot of work which is happening, they've recognised the benefits of a wellbeing service and looking at all the factors that can help people optimise their mental well-being. And I think if we could take some of that learning and bring it forward to a much earlier period of time, then that can make a really profound difference to people at sort of getting that help before they start developing more sort of ingrained pervasive mental health issues. So there's definitely lots happening.
But Joanna, I'm just very conscious that Leslie has to. I committed that she could definitely go in about 2 minutes' time.
This is a question for Dan. So yeah. So how do people access a mental health nurse or a mental health service at their GP practice? So do they have to go down the route of trying to contact their GP practice, i.e. via telephone or e-consult, or can they self-refer directly to you?
So at the moment they get through, it depends on what the practice has in place. So it primarily is actually getting through either by phone or an e-consult. Once they get through from that, then across all the services, anybody who says that they have requirements to speak to somebody about mental health will get booked into the mental health access coordinators. And I think over the last 18 months, they've had 14,000 calls they've spoken to, 8,000 separate people they've spoken to within that time period. And 100% of those have got a call back within 24 hours. So it is changing from where you had before, where you would have a perhaps 2-week wait to see a mental health, to see a GP, and then the GP would say, oh well, actually you need to see a mental health nurse, and there's another 6-week wait for that. You're actually getting getting through to mental health access coordinators nearly on every occasion on the day, and for 100% of people within 24 hours, unless people have said they can't make it within that. I think one of the key things as well is that actually 80% of the people who got through to the mental health access coordinators, after having the education, have chosen to go the non-medical route. So they've chosen to go to the wellbeing service, through to another organisation, to Paragon, to whatever is they feel is the most beneficial place to get. So that's actually had a massive impact on our ability to provide medical provision as well. So our mental health nurse wait has gone from 6 weeks down to a week. That means that those who really do need the medical model have got a much more timelier process. And it's, I said, it's getting access to those other third sector and other organisations has made a really important, really big difference.
Sorry, I'll bring you in a moment, Sir Claire, but I'm conscious of time. Sorry.
Simple question about accessibility to top management. Because within new organisations now on the surface, and I mean, we're talking about the trust initially, but it also applies to the PCB. It's my belief that there must be at least a series of public meetings held by the top, like the trust board here on the Isle of Wight, where people are come and actually sit down and see the top managers in action making those decisions. Otherwise, it's, otherwise you're still a bit far away, So it's a way of actually bringing you to the community and giving the community an opportunity to perhaps say a few things.
I'm just.
Absolutely. So as I understand it, that is one of the plans that they will move round. But the other thing to say is the new organisation will be a foundation trust, which the Isle of Wight Trust isn't. And one of the differences with a foundation trust is we have governors. There's a board of governors, and there will be Isle of Wight governors, and that will include members of the public, a member of staff, and people with lived experience. And I was talking to the I don't know what his title is, head governor, probably isn't that, but something along those lines, the other day about the process for recruiting those people. And he was really keen that we take a very engaging process, that we do, as you say, that we have public meetings where we explain what the new organisation is about and what the role of the governor is from a specifically Isle of Wight perspective. There will always be Isle of Wight governors in the constitution of the new organisation. So we want to get that off to a really strong start. And I think there's a real opportunity in that process to have those kind of conversations as well.
Thank you very much, Leslie.
Know that you need to go and get your, we do not want you to miss your boat.
No.
So I'm going to close at this stage, right? But for you to go. And if Claire then wants to ask a question, I'll make sure. But thank you. Claire, do you want to ask your question?
Yeah, thank you. Mine's more of, I've picked up everything that was going on in the meeting so far, but I think the one thing that we need to raise to Leslie to keep reminding people is actually there is lots that goes on in schools and stuff like now to teach people about healthy mental health and to look at yourself and know when you're going to aim for a crisis or recognizing it in your friends and stuff like that. But there's a group of us in this room who are, over 40, definitely over 50, that actually we didn't have that in schools. And, and I know with my own group of friends that even as a woman, it's really hard still to discuss or recognize within your own peer group if something's going wrong. And I think it would be really helpful if we could remind the NHS that there is an age group of people who were told to man up and get on with it. And actually, you don't know where to look or even that you need to look until you actually have hit crisis. And I think that's the bit that we are doing a huge amount, and everyone recognises there's a huge amount to be that is done. But I don't think enough is actually done to raise people's awareness of this is happening to you and the black dog is there, because lots of us have been in that situation, not actually known it until it's actually there on our doorstep. So that's what I'd really like to see, is that awareness of people of our certain age group who, but that's the bit I think that's really, really missing. that we don't do enough to show people where to go, or that's actually happening to you. And I think that's really important because it will stop people going into crisis.
Yes, very happy to take that up, and yeah, I fully agree with that. In the interim, there is some extremely good training on the counsellor portal. Kate Golding, who we actually saw on that film, she delivers fantastic training, and part of that training is signposting that feedback that is available. I mean, I think again, it comes back to communication, doesn't it? It's not necessarily that the help and the services and the support aren't available. It's about actually communicating it to the group of people that actually need it. But I think, you know, as I say, there is some very good training available for counsellors, but it's certainly something that I'm willing to take up.
Thank you. My point is that actually there is an age group that don't recognise it. That's my point. Not that but it's not just communication. It's actually making people aware that this is how they're feeling and why they're feeling it. Because, you know, they won't bring the doctor. They won't do any of that because we are really built with this. Let's just crack on with it. You know, get on with it. You know, that's the way that we are. So that's the bit that I really want. That it's more of an awareness than a training. Because if someone came to talk to me when I bore them absolutely asleep, so they don't want to do that because I'm a politician. But it's actually knowing that you feel like that in the first place. And I think there's a certain age group that it just misses. Thank you.
You reminded me about something today. I was having my hair done, and I was at the barber's, and as I was sitting there with a group of other old men, you actually had one of your posters, and we were all reading it together. And actually, I thought that was excellent of actually having that information in barbers. It has been done, I know, in other parts of the country, but I always thought that was really good. And there was at least 6 old men that were reading it, and we had a bit of a discussion while we were waiting for our hair.
I think since pubs have closed, and so that meeting point that men had on their way home from work or Saturday afternoon after playing football, where even though they probably didn't air their innermost emotions, they had a place where they could just talk generally, whinge and whine, has gone. And there was always that point that, you know, barmen were the priests of the working classes. And I think now that has become barbers. So we've made a conscientious effort to approach the barbers within Ryde and say, look, if somebody comes to you and they start talking and they say they have some issues or problems or they're feeling down, you know, have our cards. And that has worked really well because you do speak to your barber, you know, so hopefully we'll become, you know, services like ours will become that new something for the weekend.
I'm very conscious of bringing this to a close now. Thank you so much. It's been excellent to see the link between the different mental health services within that. If I could put a request over to Leslie and to the ICB, it'd be really good if someone, or primary care, could have a kind of journey map of all the services, because we haven't mentioned social prescribers and things. There is a range of services, and it'd be really good if we could, say at a future meeting, get back a kind of journey map that actually recognises all these different organisations.
Just to say we recognise the need for that, and I think for everyone to understand the different parts of the service. So we as part of the No Wrong Door, there is work looking at each of the individual parts of the system at the moment, and they're all collating their own part of the pathway. And then we have a plan to bring all that together to create one system-wide pathway. So hopefully that should be ready within the next month or so, and certainly we can send it through to yourselves.
I have seen recently a ride guide, which has gone into all the houses in Ryde, which is very good, and it actually lists all the organisations and different pathways. I don't know if you can get hold of a ride guide. I should have brought some, but they're quite useful. Perhaps we could have a Ventnor guide and a West White guide and etc. and Arreton and Newkirk guide. Can we, I'm going to close it now. So thank you for coming. If you wish to depart, you and get warm, you're very welcome. And we'll try and get the heat.
Before we do go, I would just like to thank all of you for the opportunity of being able to come in and talk about what we do, because it's the only way that awareness really gets raised with people like yourselves, the movers and shakers and decision makers, is to actually see what we're doing. So thank you very much for the opportunity, Michael, to come along and be a part of this.
Before we move on, does anybody want a quick comfort break? Everyone, or would you like to get on with it? Shall we move on then?
Yeah.
Okay. We've got item 8, which is winter implementation, which is pages 31, 38. Don't know who's actually presenting that. Is that you, Juliet, or you, Natasha? Right.
The paper just talks in brief about the plans that the Isle of Wight Health and Care System has made to prepare for winter. Winter comes every year. We are quite used to it by now. We are very much taking an integrated approach across health and social care. Each sovereign organisation has its own plan, as it should, but we also have a single system plan coordinated by the ICB. It deals with the escalation required over winter effectively. We know that our most critical and vulnerable time for our services in terms of demand outstripping capacity will be in early January. That is always the case. And each organisation has its plans to make sure that we safely deal with that as much as possible. That doesn't mean that it is without risk. There is always risk. It is the same risk that we mitigate all year round, which is that our services are operating at the peak of demand most of the time. And so the hospital runs at a really high occupancy level in terms of bedded care. Primary care is running at absolute capacity in terms of access to urgent treatment. And our community services are stretched as well. We know this, we recognise this. We also recognise the demand increasing for domiciliary and social care. And we are all working together to mitigate that demand by preventing demand in the first place where it's possible to mitigate both attendance and admission at the front door of the hospital, and putting additional capacity in to support the movement of patients into the most appropriate place for them at the right time in relation to domiciliary and social care. Nothing more to highlight. Happy to take questions.
Joanna, and then John.
You've half answered my question, because the paper seems quite focused on acute care. And yeah, obviously there are pressures in social care and primary care as well, but you've kind of answered that. But I just wondered, so there's an escalation process if the trust is under pressure. Are there similar so if primary care is under particular pressure, there would be a similar escalation process, so other services would be aware? And is that the same for social care?
So all of the health services share a similar or same escalation framework. So
all of the health services use an OPAL operating escalation level, which we all recognise and can talk to each other about interchangeably. The ambulance service uses REAP, which we also recognise in the context of OPAL and can share. It might be wise to ask Laura about the escalation for social care. I can't speak to that specifically. What I can say is that we do, as system partners, will call what we call a GOLD, or a strategic escalation level, when any of the parts of our system come under immense stress, and we come together to talk about how we will collectively work to alleviate that stress. That includes primary care, and we have over recent months implemented a new Apex reporting tool in primary care that talks to us about how access in primary care is being managed. So we have much more visibility of that this year.
Laura, would you like to come in? Can you come in, Laura? Put your hand up.
Come in, Laura, your time is up.
Is she able to come in?
I don't know whether I'm with you or not. It says that I'm
well done.
disabled on this end, so I'm not sure whether you are receiving me. From an adult social care point of view, we have a similar OPAL framework that's applied and has been shared with our partners. We were one of the first local authorities in the country to develop our own framework and have been really fortunate to be able to share that with the Association of Directors nationally. The national framework has been founded on the work we undertook here on the Isle of Wight. So that's a very positive step forward for us as a local authority, but more importantly for local people. What it does mean is there's a consistency in terms of the way in which we respond to challenges across the system, be they in health or in social care. The relationships that exist and the framework for addressing concerns is as consistently applied to adult social care as it is to health partners. We have the same ability as our health partners to call for those escalation meetings that Natasha referenced, and we are engaged in all of those escalations as and when they arise. For us as a system, as a county, as the island, we tend to see the greatest pressure coming to bear in our acute trust, which is why for us and our winter planning, that tends to be the core of the planning we undertake together. For adult social care, there's a separate winter plan in place, as there is for all of our health services and our health partners, and we continue to develop those together. Where there are challenges, those challenges are addressed together so that there's no intended or unintended consequence on a different part of our system. So I hope that that's helpful.
Thank you. Any questions, John?
Yeah, it's just really to reiterate that this highlights again why we wanted that 111 data on abandoned calls. And I shouldn't have to say it, but I feel that I've got to say it. And that is a reminder to bear in mind accessibility, that not everyone has access to electronic devices. Not everybody can read. And there was one case that I took up a year or so ago where a deaf gentleman was told to phone his surgery. Well, you know, have you ever tried having a conversation with a deaf person on the phone? Not really very good, but you know, the absence of consideration towards accessibility is quite outstanding, I think, across services.
If there are specifics, I'm really happy to take specifics and talk to you about what we can do to make that experience better for our residents. Those are quite general comments, so it's hard for me to give you a full response, but really happy to take specifics and we'll work on them together.
I think it's important. I mean, thank you, Natasha, and also thank you, Laura. I think we're in the winter now. We're feeling it tonight, I think. I think the key is probably March, or probably the meeting after the March one, really to have a report back. I think why we particularly wanted to keep this item one was the lessons learned from last year. And I think you have put in improvements into this year from those experiences last year. And I think the key is to report back to this committee that what lessons have been learned, have there been improvements from previous year, etc. So we'd welcome you to come back on that.
Yeah, really happy to do that at the end of winter. Yeah.
Thank you. If we could move on to item 9, which is the update on dentistry. This is been a priority of this committee. It's something that we have kept on the agenda because we felt we needed to track it. I do know a number of us have got some comments and some views on this, but if we could actually go to you, Natasha, first in presenting your update.
So dentistry is close to everyone's heart, I'm sure, as residents of the island. The provision of NHS dentistry on the island is patchy and sparse. We recognise that. The ICB has had responsibility for dental commissioning for just about a year now, taken from NHS England specialised commissioning. So we are doing our best to get very quickly to a place where we can stabilise the position on the island. First intentions to not make it worse, and then to try to work to make it better. The 3 actions that were agreed as the initial part of our dental strategy were to bring a dental mobile vehicle to the island that is due to commence in January. That will provide treatment to residents on a prioritised need basis. So primarily we'll probably be looking at vulnerable children, looked after children, and residents with learning disabilities who have been unable to access dentistry. The second action is around stabilising the loss of NHS dentistry on the island, and the action there is around the changes to the way that the units of dental activity are contracted and commissioned. We found that there are some practices perhaps next door to each other who are being paid different amounts for the same unit of dental activity, and that is a disincentive to dental practices to provide NHS dentistry. So that action remains with NHS England to approve, but we're hopeful that from Q4 we'll be able to start a pilot on the island that might prove fruitful for us. And there has been additional capacity commissioned, 15,000 additional units of dental activity provided by existing NHS dental practices, and that is available to residents now. So this is by no means a solution. We recognise that there is much more to do on dentistry on the island, but this is a step in the right direction. There is a draft dental strategy that has been circulated. If you haven't seen it, I'm very happy to send it to you. And that is being consulted on at the moment with a view to being finalised this month.
Have members seen this draft strategy? Sort of.
No.
Can we make sure that the draft strategy is circulated to the committee members of that? Before I sort of open it up as chair's privilege, I'd like to. I mean, I welcome, you know, the recognition that we need to get the services, but I do have my concerns, right? My own dentist, my dentist in right, it's not my dentist, it's called my dentist, has actually written to all the NHS patients to say, if you want to stay with the practice, you will have to pay private. We are not going to have any more NHS patients. So where those NHS patients are going to go, I don't know. People are being encouraged to pay for a plan within that. That practice is one of the major practices in Ryde. That I also know that the My Dentist in Newport is actually closing down. So you can understand from a lay person, right, and for an elected member representing the community, it seems to be worsening, not getting better. And that's really concerned. So however you are doing things, and it seems, and I might be wrong, but it seems that there's been targeted help on the mainland, right? But the situation in Isle of Wight, which has been recognised by you as being worse than other areas, Hampshire, Portsmouth, Southampton, is actually getting worse here. And I think we do need to get some kind of message over of when it's going to stop. And I mean, I have got a question, which I'll, after people speak, from I'll actually read it because I think it's relevant, through Councillor Andrew Garrett, which you have supplied him an answer. But I think the question is very important. The committee's continuing oversight of the dire situation regarding access to NHS dentistry on the island is welcome. The briefing of the committee comments that evidence suggests dental access issues here are the most pronounced. My experience talking with residents is that the evidence is more than suggestive. What advice can you give to residents on how quickly the actions will see them able to get NHS dental treatment that is both physically accessible and available on an ongoing basis, so treatment is not ad hoc? I think that's the core question in that regard. And I won't read out your full response because that will take too much time. But I think that the key is, I think we're all here thinking, what's the message we can get out to residents? Because there's residents with some very poor teeth that need help.
If I had an answer to that, Chair, I would give it to you. And I think it would be foolhardy of me to suggest a timeline where dentistry on the NHS on the island was somehow magically fixed. It is not going to be an overnight solution. The state of access to dentistry on the island hasn't deteriorated overnight, and it's unlikely we'll be able to fix it. Probably, I would suggest you're talking more about years than weeks. As always, workforce is our single biggest issue in this regard. It is difficult to attract dentists to the island. It's difficult to make NHS dentistry on the island an attractive proposition. That doesn't mean that there aren't solutions, and so part of the dental strategy talks about how we would grow a workforce to support ourselves, but those things also take time. We are doing everything that we can in terms of trying to stabilise the position so that patients don't lose access to the remaining NHS dentists they've got. I appreciate the examples you've given don't speak to that being successful so far, but one of the key initiatives in that area around the unit of dental activity costing hasn't yet taken effect. So once that's signed off, we hope that that will start to stabilise the position. That's of no comfort, I recognise, to those patients that have lost their access in the last week or so. This is a long-term strategy. It has to be to make it successful. And a lot of that is about how we get the right people here. And there are dentists here who may offer NHS dentistry again if we can make the offer attractive enough, but clearly that's not been within our gift thus far. But we are working on that with NHS England.
So I can't not comment on dentistry. And we still get an awful lot of feedback, and it's one of the main reasons people contact us still. And we've had a lot of contact today around the dentist closing end of January, because people come to us and say, where can we go? And we still have to say, I don't know, all you can do is ring round, and we give them contact details, and it's really disheartening that that's all we can give people. However, I feel services have now recognised the issues over here, and people are listening to us now, which is something positive, and action is being taken. So we've got a dental bus coming over. It would be helpful to have more information about that, about referral process, where it's going to be located, so that can get, happen as soon as possible and as swiftly as possible. It's disappointing that the stabilisation project is going to take, till the end of 23, beginning of 24. I wonder why it's going to take so long. But also on a positive, because I'm always moaning about dentistry, and I'm sure people are fed up with me at every meeting bringing this up, but it's just so important to local people, from children right through to elderly people that can't get false teeth fitted. It's across the whole population of the island. However, we're really heartened that there's some working groups set up. And I understand there's good representation from local dentists from the island, and also from Healthwatch. We are represented on those groups, and we have rallied round the dentists to get them to engage with these working groups, because it's absolutely key. The working groups are for Hampshire and Isle of Wight dental provision. So it's key that we get island providers on those groups, sorting out solutions for island residents. And it's the dental providers that will provide us with those solutions. They have the answers, and there are some fantastic NHS dental providers on the island that are really keen to support with this and to do more. They just need to be given a green light to do that. So there, at last, I think there are some positives, but it would just be really heartening to be able to give people something more tangible in the short term, and hopefully if we continue focusing on this issue and keep it at the forefront of people's minds, hopefully we will get there.
Thank you. Joe?
Thank you, Chair. 2 questions from me. Last time we had an update, I asked for some sort of time, because a lot of things to steps we're talking about what we needed to get where we need to be. I asked for a timeline. I appreciate people that might not want to put dates and on things, but I think, and it might be in the strategy, so I don't know, it might be in the, I'm just looking for what are those blocks, that those things that we're putting in place, and in what order to get us to a good place. I'd just be keen to see that, just so I'm aware of how we're getting there. And then I'll let you answer that, actually, because the second thing's escaped my mind right now.
So clearly some of the actions were more immediate than others. The bus in the next few weeks, we're just finalising that. The changes to the pilot for UDAs, it might not be, it may well be earlier than the end of March, Joe. It depends on NHS England approval. So that can take some time to work its way through, but that could be January, it could be February. I'm not absolutely clear when we're expecting that yet. And obviously additional activity has already been contracted and is available now and has been snapped up, I'm sure. The dental strategy talks about the long term. So it talks about and what else? Those are just sticking plasters. So what is the next thing? What do we do to build viable NHS dentistry on the island? And so, as Joanna said, there are some workshops that involve providers, and that's about finding the solutions together and working out what it would take to make a difference. That isn't an overnight thing. That's the kind of, how do we get from where we are now and really look forward. But like Joanna said, I think, you know, there are green shoots here. There are things happening that weren't happening before. So
Thank you. The second thing's escaped me, so yeah, I'm happy to move on, sorry.
Any further questions? No, thank you. I mean, thank you for being candid, right, about it. Would it help, one of the things, you know, as chair and this committee is we can be proactive. We did recently with the transport providers, we wrote to them. Perhaps we could write to all the dentists on the island from this committee, asking them to engage, perhaps to, you know, make them that we're very aware and that their involvement would be really encouraged.
I won't stop you, Chair, but most of the providers will have been contacted as part of the dental strategy already and are to work with us on the dental strategy and to attend the workshop. So I suspect they've probably already got that message clearly from us.
The other part of it is, would it help us to communicate to NHS England that we as a committee would like this to be sorted out and them to respond as soon as possible, or would it not help?
I think perhaps that may not help us. What I would suggest is if we haven't got an answer by early January, perhaps I can come back to you and take you up on that offer.
Well, I'm going to make a suggestion, committee, that we put forward a resolution. I'll do it from the chair and hope for a seconder, that we support your efforts to get into the right direction, but we want this to stay on our agenda for the next meetings as an agenda item, so that we can track for the residents of the island that this is a priority or priority issue, and we're not going to let go of it until we actually see good outcomes. Is that got a seconder from Joe on that? Yeah. Do we all agree with that? Okay, thank you. And thank you regarding that. If we move on to the next, I've lost my work plan. The work plan, thank you. Thank you, Deputy Chair. We look at the work plan. Any comments on that? I'll just raise the issue that on the health, on the budgets, we had a very, very good informal meeting previously, and that's going to come back in January. That is
it might be useful.
All the health providers.
Might be useful to ask health partners if there's anything they particularly like us to put on the work plan.
Of that, is there anything you particular?
Nothing to add to the work plan. I would just note that in January, health budgets will not have been set at that point. So I think your process is run much earlier than the health budget process does. So we can come and give some indicative feedback, but it's unlikely at that point that we will have full clarity about the health budget.
Do we want to move it back? Would it help if it's moved back a month?
We probably won't finalise our position until the end of March. So we can come and give indicative kind of overall feedback about what it's shaping up to be, but
yeah. Sorry. Oh, sorry.
Can I ask a question? It might be that I'm missing something, but the Adult Safeguarding Board annual report is on in March and also in December, but there's no Children's Safeguarding Board report. So was one of those meant to be? Right, but if it's coming in March, is December seems quite early to bring the next one if it's an annual report.
Melanie.
The report normally comes in December, but there's been a delay for this year, which is why we're then getting it in March. So the December is the normal time that we would receive the annual report, but it's just delayed this year.
Okay. Any other comments? No, let's move on to the last item. We've got members' questions. I've had two. We dealt with one through Councillor Garrett, and I won't read out the response, but we'll circulate it because you've actually given it in the answer to Dentistry in your report, really. The second one is from Councillor Mosdell. She has gone, so I'll read out her question and answer, but then as members, you might wish to contribute. This is a question from Councillor Claire Modsall to the Policy and Scrutiny Committee for Health and Social Care. The transition to ICBs over the last 18 months was intended to bring decision-making closer to the point of care. Last year at the NHS Confederation Conference, Steve Barclay highlighted how this change from CCGs would ensure there would be a place-based approach to tackling health inequalities through local commissioning. However, on the Isle of Wight, the Hampshire and Isle of Wight ICB move has taken decision-making powers to the mainland and removed the island's autonomy. When coupled with the financial position of the Hampshire Isle of Wight ICB, the island's separation by sea and additional barriers to sharing services with neighbouring areas, we are seeing a potential loss of funding for primary care on our island of close to 1 million this year alone. Will the Policy and Scrutiny Committee for Health and Social Care direct officers to make representations that encompass our unique position and hence ensure that all island factors are taken into account in decision-making by senior health administrators at a place-based island level? Because it was to the committee, I'll give you my response as the chair of the committee, but I will be opening it up if people wish to add. I thank you for the question, which is poignant, timely and relevant. As chair of the Policy and Scrutiny Committee of Health and Social Care, I have been deeply concerned that the restructures of the new Hampshire Isle of Wight ICB, the new Portsmouth and Isle of Wight Hospital Trust, and the new Mental Health Trust covering Southampton, Portsmouth and Hampshire and Isle of Wight Fusion Project has taken away the autonomy of the island and reduced the island's voice in governance in NHS bodies. The committee has tracked these recent changes and received briefings, including the financial implications of the new bodies such as Hampshire Isle of Wight ICB. This is on our work plan, and we will have a further briefing in the new year on the 2024-25 budget. I have recently requested for a list of all the island representatives on all the new NHS bodies relevant to the island, so the committee can establish strong communication links and make sure the needs of island residents are strongly represented. Health Watch Isle of Wight is working with all the other Health Watch organisations across the new regional bodies in this regard. I have spoken to senior management of all NHS bodies and raised my concerns as chair and sought reassurance that the special needs of the island and the additional costs, financial and welfare, attributed to the crossing of this island are not lost but prioritised. I'm working closely with Health Watch Isle of Wight, part of the committee, and the scrutiny officer to track this NHS transformation on the island and regularly communicate with NHS senior management and those islanders who sit on the new governing bodies. I am grateful you have raised the issue of commissioning, which has always been a deep concern of mine, as this is about services at grassroots level. It is essential there is a clear Isle of Wight identity within the commissioning process, as certain mainland services do not fit well within an island context. In a recent meeting about Project Fusion and the place plan approach in regard to mental health services on the island, senior NHS managers praised the network of peer support grassroots projects. They saw Isle of Wight as a beacon of excellence regarding peer support and the Mental Health Alliance, and emphasised they wish to use this model as an example of good practice. As part of my response to your question, I will put it to the whole committee on the 4th of December as a way of getting a collective committee resolution that publicly recalls our concerns about making sure these changes brought by national government and NHS do not have a negative effect on our residents, which we fear. The Isle of Wight Council approved a motion at its last full council brought by the Liberal Democrats to consider all inequalities, including health, between the island and the mainland, and how best we tackle these, whether through lobbying government or seeking legislation. We have a duty as the main elected body on the island to advocate this evidence island inequality. If the committee endorses your and my concerns through a resolution, I will write to all the NHS relevant chairs and CEOs, and in particular the Hampshire Isle of Wight ICB. As representatives of these NHS bodies attend the meeting on Monday, there will be an opportunity for them to respond as well. As a committee, we also have the mechanism of being able to raise any concerns with Parliament's Health Select Committee. As you say, the Conservative government implemented this infrastructure restructuring commissioning in regards to Hampshire Isle of Wight ICB as part of a place plan based approach, which appears contradictory when the majority of decision making now will be from the mainland. Perhaps in your role as the Isle of Wight Conservative Group leader, you can write to the Health Secretary and the island's current existing Conservative MP as well and raise your concerns. And that's my answer. If anybody from the committee wants to add, or whether you want to reply, Natasha, although I'd accept you digesting it and perhaps replying in writing.
I will take the option to reply in writing, Chair, but I will add that there is a strong place-based management team on the island. Both Darren and myself are island residents. We advocate strongly for the voice of the island in decision-making with ICB executives, and I do not feel any sense that our voice has been lessened by joining with our Hampshire colleagues. What it does give us is the opportunity to work strategically to tackle some of the long-standing issues that the island has around sustainability and workforce, and that is incredibly helpful for us. I don't think that it has disadvantaged island residents. I think we have the opportunity to make it a more sustainable system, a more affordable system, and to work together across Hampshire and the Isle of Wight to promote better health for all of our residents and population.
Thank you for that. And I think perhaps you might want to add to your reply to my reply, but part of my reply was accepting that I have had those conversations. Laura, you wish to add to that?
Thank you, Chair. I'd just simply wish to make clear my thanks to Natasha and to Darren Cattell for the support that they provide to us as an island at a place level. Natasha is absolutely right. We do have a very strong place team, but inevitably the island is a small part of the overall Hampshire and Isle of Wight Integrated Care Board's remit now. What we often find is that there can be confusion in terms of what the ICB actually is, as locally it has two different forms, and very helpfully we use the same term for both. The Integrated Care Board is a legal entity of its own. It is the successor to the Clinical Commissioning Group and is a standalone organisation who makes its own decisions, as we as the Isle of Wight Council do. We use ICB interchangeably to refer to the integrated care system, which is part of the Integrated Care Board's statutory remit. And that's the part where they're charged with what is inevitably a very difficult job, supporting all of us as system partners to work together to achieve the best outcomes for local people. And in the sense of the integrated care system, that's local to Hampshire, Southampton, Portsmouth and the Isle of Wight, not just the Isle of Wight specific. Through our own Island Health and Care Partnership, there is a strong and committed view and push to ensure that island residents are not disadvantaged. And I'm fortunate enough to be a representative, certainly for a 12-month period, within the Integrated Care Board as a standalone organisation, with Simon Bryant chairing our Integrated Care Partnership across Hampshire and the Isle of Wight as well. So I think there's possibly more in terms of a response to Councillor Mosdell's question than simply it would seem on the face of things. That recognition that the ICB is both its own sovereign organisation, but also the term we apply to our system approach is probably key in terms of the response and the place-based agenda that we all value so very deeply.
Thank you, Laura, for that. I think it's very good, and it would be actually good to communicate that back and to Councillor Mosdell as well. Thank you. Joe.
Thank you, Chair. Not to drag this out any longer, but just a couple of comments. I think I take slight issue with what Councillor Mosdell submitted, because I think we can be critical of the structure, but the implication of what I interpreted from that was that we don't have people advocating for the island already. So I'm glad Natasha's rebutted that, because I've not seen any evidence myself that Natasha and Darren and others aren't already advocating for the Isle of Wight. So I think we need to be a little bit careful there. Second thing, I'd really appreciate, especially questions of that length and responses of that length, that if they're not asked in person, that we just get them emailed to us so we can, because apologies, Chair, but half of your response went over my head a little bit because we're at the end of the meeting. It was quite lengthy. I think if people aren't here to ask them in person, then we get them in email. I think that's probably a good strategy going forward. Is that all right? Just so I can absorb it properly. Yeah.
I felt it was important publicly to do that one because they said councillor was here to the period of time, and I felt it was important to involve our colleagues. But I take the view that now there's no other members' questions, so I close the meeting and thank for all your attendance, and thank you, Juliet and Natasha, for your input. Thank you.